All right, you're good to go.
Okay. Hi everyone. My name's Christine Connors. I'm a public health physician working in Darwin. So the session that I wanted to take you through today was to really look at different ways that public health physicians can lead and influence in terms of particularly service improvements. Typically, a lot of public health physicians work in infectious diseases or epidemiology or health service management. A lot of the work I've done has actually been in primary care, chronic disease and continuous quality improvement. And certainly in the NT, we've found that public health physicians have been able to be very influential, particularly in terms of improving Aboriginal health and Aboriginal health outcomes. So this session that I'm doing today, I'd actually put together for a National Aboriginal Health Summit that was held in Darwin a few months ago with representatives from each of the health departments around the country with their senior Aboriginal health policy people, as well as some senior community-controlled organisations from around the country as well. And the theme that I was using for this particular talk was around partnerships. In the NT, we have what's called the NT Aboriginal Health Forum, which is a partnership between NT Health Department, Commonwealth Health Department, the Aboriginal Medical Services of the NT, so that's the alliance of the community-controlled services in the NT, and then in more recent times we've had what's now the Primary Health Network, so you know, what was previously Medicare Local, GP Division, etc. And that group, that forum group, acts as a peak group to monitor and oversight and make joint decisions in terms of key issues in terms of delivering effective primary health care for Aboriginal for Aboriginal people in the NT. The majority of Aboriginal people in the NT access health services either through government or community-controlled services, with over 75% of people living in remote communities, whereas of course in many other jurisdictions that's not the case, where the majority of Aboriginal people may well be living in the metropolitan area, and so while some of them access their services through community-controlled services, many are accessing services through private general practice. So certainly we have an advantage in the NT in that the Aboriginal primary healthcare sector is mostly run either through government or community control, and through Forum we've then been able to have develop joint systems, use joint protocols, use joint auditing processes and report against joint key performance indicators, and all of those have enabled us to actually be quite focused in terms of what are some of the outcomes that we're trying to achieve. So I'll put it on full slide. I'm just hoping it doesn't sort of take itself away again because it's been behaving a bit strangely, as you can see. Some of the things that I talked about at this forum was, first of all, to look at the CEPA quintile. So this is taken from AEDST census data, and of course what you see here is that for Aboriginal people across the country, apart from the ACT, huge disadvantage. So the red is the most disadvantaged quintile, and of course what we should see is that 20% of the population is in that group, whereas across the country it's ranging from 39% in Victoria to 59% in SA, and of course unfortunately in the NT it's up to 74%. Across the country it's 51%. So the only area that doesn't have a disproportionate representation is the ACT, where of course a number of Aboriginal people have moved into the ACT working in fairly senior government and non-government jobs. So when you look at that level of social disadvantage, then hardly surprising that we're seeing such poor health outcomes for Aboriginal people. We know the relationship between social disadvantage and health outcomes. This particular slide is from NT data, and it's looking at what's causing the gap in life expectancy. So the bottom line looking under males, is the life expectancy for Aboriginal men, and the top line is life expectancy for non-Aboriginal men, and so the coloured band is one of the key things making up that gap in life expectancy. And so what we see for men is about a third of that gap is actually due to social disadvantage, and then a significant proportion of the gap, about 20%, is due to smoking. And for Aboriginal women, it's even greater. About 40% of the gap in life expectancy is due to social disadvantage. And it's useful having this type of data to show not only to health staff and policymakers, but also to show to other government departments, because it helps to demonstrate why, if we're going to see an improvement in health outcomes, and particularly an improvement in closing the gap in life expectancy, then changing the social disadvantage is critical. And just for people who aren't familiar, hopefully most of you are familiar, the evidence now is that poor social determinants actually impact on our health status through causing chronic stress. This slide is showing, multiple factors in terms of social disadvantage and how they each play out through chronic stress. In this particular case, Fran Gorman put this together to show psychiatrists how poor social determinants impacts on mental illness. And then, of course, often people are coping with the chronic stress by using various substances, which then often aggravate their poor health status. So this is showing across the country NAPLAN scores, so looking at reading and numeracy, again showing that Aboriginal kids are doing worse than non-Aboriginal kids, and of course the more remote you are, the lower the scores, and again that mirrors the health status. Looking at Year 12 retention, so again, getting more kids graduating Year 12 is probably going to be one of our most successful strategies in terms of improving health outcomes. And so you can see there's still a significant gap. There's been improvement, but there is still a significant gap. And in the NT, that gap is even worse in terms of Year 12 graduation. And again, this shows really clearly. This is from various AEDST data. So this relationship between Year 12 graduation and the typical risk factors. And so you can see for kids who graduated Year 12, 30% of them are smokers, as opposed to 50% who are either Year 10 or Year 11 equivalent graduation. So that's way more successful in terms of a tobacco control strategy than probably anything we could achieve through the health system. So the data linkage projects that are occurring around the country, really, I think these create great opportunities for public health physicians to really be able to look at a broad range of data and then to be able to interpret that in terms of what does it mean from a health service perspective, what does it mean about partnering with other government departments. So in the NT, we're working with South Australia and using their data link, despite having it on the side, it's still trying to jump ahead. And we've started to link a number of different data sets in the NT from both health and education. And so this original data is looking at what are some of the underlying risk factors for an Aboriginal child having a Year 3 NAPLAN result that's below the national minimum standard in reading. And so you can see the crude risk of being below the national minimum standard is an Aboriginal child and has a risk of 8.6. But once you adjust for all of these other risks, then that reduces to 2.9. So there's still things that perhaps we haven't quite fully captured, but it's not being Aboriginal per se, it's prematurity, it's young mother, it's gender, it's parity, it's mother's education, and it's living in a very remote area. And so you can see that all of these are significant risks in terms of reducing the likelihood of a child being at the national minimum standard. And I guess the thing with this particular slide is this is a great way to engage with education departments and to really get education department and health departments thinking and working together, because within this slide we're reflecting the issues that education department's interested in, and of course, so that's NAPLAN scores, reading, numeracy, etc. But it clearly shows where health can help to influence. So, you know, the age of the mother, for example, so health can influence through, obviously, sexual reproductive health education, access to contraception, mother's education. Well, that's clearly an influence from the education department itself. There's some things that can't be changed as such, so if you're living in a remote area, but it's not so much living in the remote area, it's more about, well, what is the disadvantage that that is bringing that's then leading to this low NAPLAN score. So this slide is showing the relationship between delivery of primary healthcare services and hospitalisation. And again, in the NT, in the Aboriginal primary healthcare sector, at least in the government sector, we have one primary healthcare information system that we use, which means that you've only got one record, whether you're being seen by a health service down in the desert or being seen by a health service in Arnhem Land. So first, that's a huge advantage, both for the clinicians who are delivering the service, they're just looking at one record, but also for epidemiologists when they're analysing data. And we have a unique identifier, so we can link the primary care record to the hospital record and also to death records. And so we're able to do this analysis that's often not available in other states where you don't have this same type of unique record, unique record number, and then also having the single record. So again, this one is very useful and very important data, and shows the benefit of some of the primary healthcare systems that we've been working on in the NT. So it's looking at attendance at the primary healthcare service, and then whether or not people were hospitalised according to their rate of attendance. And so what they've shown is this U-curve, which is actually quite novel. There's this group of people at this end of the spectrum who did not attend at all within the last 12 months and were much more likely to be hospitalised. And then there's a spectrum of people who are coming on a really regular basis to their primary healthcare service and are also much more likely to be hospitalised. And then in the middle here, there's the bottom of the U-curve. So there seems to be an optimal point whereby if you're coming a certain number of times, your rate of hospitalisations is lowest. And really what it is saying and confirming is that attendance at primary health care and receiving, you know, recommended checks if you've got a chronic disease or vaccinations, for example, will actually prevent hospitalisation. So again, I've been able to use this as a public health physician, both in terms of informing and motivating primary healthcare staff and showing them that if they're delivering care according to our protocols and guidelines and achieving outcomes, one of the significant outcomes they'll achieve is to reduce hospitalisation. And then it's also very useful to show to the Health Service Board, because it is much cheaper to deliver the service within primary healthcare than it is to deliver it through a hospital setting. And so, again, it creates a strong argument that funding and supporting an effective primary healthcare service, particularly in our case, in remote settings, is much more cost effective for the Health Service Board. Otherwise, they would be spending a hell of a lot more on hospitalisation. Oops. Sorry. So this next slide is from the same data where they were looking at different groups. So they were looking by age, by gender, by preventable and non-preventable conditions. So I'm assuming all of you will have seen papers that talk about preventable hospitalisations and preventable mortality, and pretty much preventable conditions fall into three groups, with the biggest group being chronic conditions. So an obvious example is a diabetic foot ulcer, for example. If you're managing someone's diabetes well, and particularly if they start to get early signs of any infection or ulceration, then you can prevent them being hospitalised and going on to an amputation. So chronic conditions, vaccine related diseases, and there's a grab bag of acute illness that makes up the third main category, but the biggest of those is chronic conditions. And certainly a lot of the work that we've done in the NT has been around effective management, so early detection and management of chronic conditions in remote settings. This particular slide is from the same data set, but another paper where they specifically looked at diabetes, and they looked at not only hospitalisation but also death. And basically what they were showing is that for the low use group, so either no or only one primary healthcare visit within the last year, that's the second column here, versus the high use group where people were coming on a very regular basis, in fact the rates of hospitalisation were 5 times as high amongst the low use group. The rate of death was 2.7 versus 0.54, and the deaths per 100 population was 3.23 versus 0.8. So even amongst the high use group, who, you know, we would make an assumption that they may well have had more complicated diabetes because they were coming to their primary healthcare centre much more frequently, even so, they still had much lower rates of hospitalisation and death than the low use group. And again, a really clear way of demonstrating the effectiveness of delivering organised and systematic primary health care. I think that's been one of the big things that we have been able to do in the NT, because for the Aboriginal primary health care sector, we manage or collaborate around it, and because it's funded, it's a capitated funded system as opposed to a fee-for-service system, then we're able to get health professionals and especially doctors working differently, whereas in the private GP system, fee-for-service works very poorly, in particular for chronic conditions, and there's currently yet another discussion paper out from the Commonwealth Government looking, again, proposing primary health care reform and proposing a capitated system, a partial capitated system in primary care for managing chronic conditions, because then you can start to achieve some of these outcomes that we can see here, as opposed to a fee-for-service, which tends to be a really ad hoc, reactive way of delivering care. So the reason the U-curve was novel is when they started to look at what was the literature showing around primary care and hospitalisations, there was conflicting results. So some studies were showing that if you came to your primary care service, you were more likely to be hospitalised. Others showed that if you weren't coming, you were more likely to be hospitalised. But because very few people have access to be able to link their primary care and hospital data, they hadn't been able to demonstrate the U-curve, which shows that both of those things were true. And that, you know, if you're not coming, you're more likely, if you're coming a lot and you've got complicated disease, you're more likely to be hospitalised. But there's this optimal point of primary care attendance where your rates of hospitalisation and death are lowest. So across the country for Aboriginal people, there has actually been a really significant reduction in cardiovascular mortality, and that's pretty much occurred, certainly in the remote spaces, despite the rates of smoking continuing to be very high. Sorry, I've got no idea why this slides are jumping around. It's never done it before, so just to be difficult today. And so what we can see for cardiovascular disease is that we are actually narrowing the gap in terms of life expectancy for cardiovascular disease, and cardiovascular disease is the major cause of particularly premature death amongst Aboriginal people. So many people are dying actually in their 30s, 40s and 50s. So it's really quite significant to see a reduction in cardiovascular mortality, and with a greater focus on increasing quit smoking, then we should actually start to see even further reduction, because of course we'll also be getting a prevention of cardiovascular disease, not just reducing deaths. And in the NT, what we have seen, so this is looking back over the last 50 years, so we have seen a significant improvement in life expectancy. So the light blue is Aboriginal women in the NT, the dark blue is non-Aboriginal women, and the black is women across the country. I'll just put that onto the main one for the minute. And so what you saw back in the 60s and 70s was a significant improvement in life expectancy, and that was very much around reducing maternal and child deaths in particular, much of which was infectious diseases. And then once we got into the 80s and 90s, we started to actually get a stagnation in terms of life expectancy. There was no real gains. And then in the 2000s, we've started to see improvements again, and this now is mostly due to chronic diseases. So the pattern has changed from 50 years ago in terms of the major causes of death, and therefore how we respond as a health system. And so again, from a public health physician perspective, as I said, we have put a lot of focus and time into really looking at how does the health system respond and how does the health services respond to ensure that we can actually manage chronic diseases as well as possible, particularly given we've got a remote setting, we have limited GP time, so we actually need to look more broadly at a workforce that can be doing a lot of the basic checks, you know, whether it's blood pressure check or taking blood tests, etc. And we've continued to refine and improve that over the last 15 years. Okay, so when you look at leading causes of death, cardiovascular disease continues to be the leading cause of death for both Aboriginal and non-Aboriginal, followed by cancers. But you can also see for Aboriginal people that external causes is a significant cause, and external causes is mostly injury. So it's injury and poisoning, but it's mostly injury, and that's a combination of road trauma and assault, basically, much of which, of course, is linked to particularly alcohol abuse. That's an area that we certainly in the NT, we have had focused work around road safety, going back 6-7 years ago, back in the late 2000s, again led by one of the public health physicians, Stephen Scove, who was actively engaging with the Road Safety Committee and bringing some rigour and evidence into the decision making, and so there were some significant changes that occurred at the time. In terms of alcohol, there's been a range of initiatives around reducing access, but unfortunately, probably both in the NT and nationally, we're still not doing what we need to do. There's been many reports and many evidence summaries that clearly tells us what is going to be some of the most successful strategies around reducing substance abuse with alcohol, much of which simply have not been implemented. So whilst we've been very successful with tobacco control, for example, we haven't made the same gains that we could have made in terms of alcohol. Things like the volumetric tax, for example, which has been proposed and has very strong evidence to back it, has still not been brought in by government. So we still have disproportionate taxes on different types of alcohol. And this one is looking at deaths from external causes. And again, these have continued to be very high, and we haven't really seen significant improvements, certainly not in the NT. And hospitalisations from injury and poisoning is also very high. And again, this is data from across the country. So this is looking at all hospitalisations. And you can see these really disproportionate rates and rate ratios. The blue dots are the rate ratios. So I think injury is an area that, from Aboriginal health perspective, is something that we haven't really had as much focus on as we should. I mean, across the country, again, the lead in injury is actually taken by a public health physician in South Australia, who does produce a lot of very useful work. But again, it is something where we probably need to be thinking about how we put specific effort and focus to really shift what's happening around that, because we've not seen any significant improvement. I'll just show you some chronic disease stuff and just go on and show you some of the KPIs that we've really been able to use in the NT. This slide's pretty shocking. This is taken from the most recent AEDST health survey data that was done in the last couple of years, where they not only were talking to people and getting self-reported data, but they were also doing some biometric measures. So they were doing fasting glucose and HbA1c, and so these results are based on actual blood glucose results. What you can see, so it's looking at people under the age of 55, and there's this very obvious difference between Aboriginal and non-Aboriginal percentage. What you can see is that for both groups, the majority of people actually knew that they had diabetes, so that's positive, and that's a big change from 15 years ago when the first AUSDIAD studies were done, when in fact about half and half knew they had it compared to being newly diagnosed. For Aboriginal people, there's a small group of people newly diagnosed, so you can see, in fact, that's true for both. And then there's a group of people who are at risk, so this is effectively impaired glucose tolerance, and so at significant risk of transitioning to diabetes within the next 5 years. But you look at that and you can very clearly see where there's significant problems for Aboriginal people across the country, where we need to be putting focused effort, why we're continuing to see these disproportionate rates of kidney failure, for example. I'm just going to skip over that. So again, one of the opportunities that we've had within the NT through the NT Aboriginal Health Forum is developing joint approaches, and so we developed the core functions of primary healthcare, and again that acts as a mechanism for the Aboriginal primary healthcare sector to focus their efforts to, we use it when we're talking with funders and policymakers, we use it when we're doing business planning with staff, so you can use it at all different levels, and we have done that. I'm just going to skip over some of these and just go on to the NT Aboriginal Health KPIs. So this has been a very useful and powerful way of really focusing effort in the NT. So this was a set of key performance indicators that were developed 10 years ago, easily, under the auspices of the NT Aboriginal Health Forum. And the original thinking through the forum was to give forum members a way of making health service delivery visible, so that they could track in more real time what was happening around the delivery of services and some of the outcomes of, some of the intermediate health outcomes. And so we developed a set of initially 12 clinical indicators, which were a compromise based on what was the evidence telling us was useful and what was feasible to collect. Because when we first started collecting these KPIs, many of the services had paper-based records. They didn't have electronic records. Now all of the services have got electronic records, and so that makes it much easier to develop mechanisms to do automatic data extraction from those records. It's not a completely straightforward thing. You still have to actually make sure the data is being collected in such a way that it can be extracted, but it's obviously less time-consuming than trying to do that from paper records. Across the country, we have very limited primary healthcare data. We've got the beach data, which is collected on a voluntary basis as a random sampling of patients. But in general, we have very limited primary care data, and this is a real gap in our services, in our epidemiology and understanding what is happening across the country. The Royal Australian College of GPs has developed a set of key performance indicators. It hasn't been formally implemented as yet. They were trialling it with some interested services. We had a number of general practices around the country, including community-controlled health services, that have participated in the Australian Primary Care Collaboratives, and so providing data on a selected number of indicators, and that's certainly been a positive initiative, but it's not funded to the same level that it has been in the past. So again, as public health physicians in the NT, we've been able to engage with these key performance indicators and use them in a really active sense, both with individual health services, with clusters of health services, and then across the NT, and using them with groups such as the NT Aboriginal Health Forum, as well as with policymakers and funders. And so what we can see, this is just grouping child and maternal health indicators. So we can see that immunisation rates are relatively high. In fact, we now have an indicator that looks at timeliness, which is giving us a better sense of where we need to focus effort. Our checks for kids under the age of 5 have shown steady improvement. We're now running at around 90%, which from a population perspective, you really want to have at least a 90% coverage rate to actually be making sure that you are capturing the key groups in the population. If we're looking at underweight and anemia, we can see that the rates have been reducing in both of those conditions, although obviously the rates of anemia are still very high. And then we're looking at first trimester attendance for antenatal care, which has been steadily improving but is still only running at 50%, and low birth weight, which has pretty much been stagnant and interestingly is actually very similar to the rates we're seeing around the rest of the country for Aboriginal women, running at around 12%. Certainly with something like low birth weight, for example, without seeing a significant shift in smoking rates, which currently run at 50%, and without seeing a significant improvement in Year 12 graduation for Aboriginal young girls, then we're probably unlikely to further close the gap, because a lot of low birth weight is actually outside what can be directly achieved within the health system. The other way that we're able to use these Aboriginal health KPIs is by looking at variations between services. So for example, if we're looking at the first trimester attendance less than 13 weeks, so we can look at trend data over the last couple of years and see that we've had some improvement from 47 to 49% as an NT mean. If we look at the lowest performing and highest performing HSCAs, we can see that we've gone from 61% to 73%. for the highest performing and 26% to 30% for the lowest performing. So in fact, the variation has actually widened for 2014 because one area is doing extremely well. However, the other things that you can look at here, and again, what I draw people's attention to is that looking at women coming after 20 weeks, in fact, on average, we've got 1 in 4 women are coming after 20 weeks. And again, there's a significant variation with the best areas only having 1 in 10 women coming after 20 weeks, and the lowest performing areas, 42% coming after 20 weeks. So focusing on those women who are coming much later is probably more likely to give us better gain than focusing on trying to get everybody coming in the first trimester. So if we get everybody coming before 20 weeks, then we are likely to probably get better outcomes. Sorry. So again, talking both through the Anti-Aboriginal Health Forum and through our Continuous Quality Improvement Collaborative, and getting health teams to understand and recognise and focus on this variation and focus on the areas that are doing really well and really trying to understand and look at what they're doing that is enabling them to achieve better outcomes, and then looking at where areas are not doing so well and what is happening within those services. And, you know, over the years we get a lot of, we've got a lot of information in terms of what are some of the underlying factors. We've been running fairly long-term quality improvement action research process through Menzies in the NT, and so that's enabled us to really analyse and dig into factors which are around staff stability, the skills of the manager, the proportion of Aboriginal staff within a team, and whether or not a team is delivering their care outside the health centre or only within the health centre. And so going outside into different community settings, you get better engagement and you provide better access to people. Alright, I'm just having a look at what I've got with some of these others that I can highlight. I'll just to show you another sort of example of where public health physicians have been able to lead and really help services to focus effort. So within the NT, and in fact in many remote areas across the country, the remote primary healthcare manuals are widely used. So these were developed as a set of protocols for particularly remote nurses and Aboriginal health practitioners, but also for GPs working in remote settings, targeting the type of conditions that they might be seeing, which you're not necessarily seeing in a major metropolitan centre. So TB, melioidosis, leprosy, for example, infectious diseases that you're just not coming across, rheumatic fever, but also the level of complexity of the chronic diseases. So the majority of people with diabetes, for example, have got complex comorbidities, which is much greater than what you find amongst the average group of diabetic patients in a suburban general practice setting. So what these remote primary healthcare manuals have enabled us to do is we can get evidence into practice very quickly. So by collaborating with Menzies School of Health Research or Baker IDI or Centre for Remote Health, for example, new clinical findings or findings in terms of service delivery, we're then able to put into the protocols and influence the way that people are delivering their care. And, you know, often when you look at research getting into practice, you can often have significant gaps. I mean, aspirin is the classic example that's often cited, where it took on average about 20 years before it became routine practice to give someone an aspirin when they had signs of having a heart attack. We can get research into practice within 6 months or less of it being published. So that's a significant advantage. We also link our clinical auditing to the primary healthcare manual, so we can actually audit practice according to the protocols that people are following. And so when we're looking at the key performance indicators, for example, and they're showing gaps in services or suboptimal outcomes, we can then link that back to relevant protocols within the primary healthcare manuals in terms of talking about service improvements. So as an example, within, I think 3-4 years ago, so around the time that nationally the Vascular Alliance produced the first set of cardiovascular risk assessment tools for Australia, which was incredibly slow, we incorporated that with modification into the CARPA Standard Treatment Manual, and then within the government sector we've been able to develop a process of data extraction so we can monitor the use of cardiovascular risk assessment. So you can see that we've gone from having just under 30% of people have had a cardiovascular risk assessment to 65% of people by the middle of this year. And this gives you an example. I'll see if I can get it to stay up on the slideshow. This just gives you an example across the NT, and you can see the red is high cardiovascular risk. So you look at this and immediately you can see this significant amount of red amongst relatively young adults, where you would not be expecting to see this level of high cardiovascular risk in people under the age of 75. So we've currently completed 64%, and of those, 34% are high risk and 56% are low risk. Even amongst the youngest adults, we've still got 5% of people who've got high cardiovascular risk. And so this is very consistent with what we see in terms of young people having heart attacks and sometimes fatal heart attacks in their 30s and 40s. And this focus on cardiovascular risk assessment, again, as public health physician, I'm able to use that in a number of ways. I use it for talking with health teams and talking about how they're delivering their service. I use it when talking to policymakers and funders in terms of demonstrating significant need and gaps in services. I use it when talking to the GPs in terms of looking at how well they are adhering to recommended protocols in terms of prescribing of statin or aspirin, for example. So you can use it at different levels depending on the different audiences and the messages that you want to give. So again, this is from our data extraction. We can look at the proportion of people who've got a high cardiovascular risk who have got very tight blood pressure control. So we've been running at around 60%. And so again, talking with the RMPs in terms of, the GPs in terms of what proportion of their patients with high cardiovascular risk are actually on an antihypertensive, so ACE inhibitors and ARBs are the recommended drugs, what proportion of them are meeting target, what proportion of them are on no medication. So again, you can actually have discussions at different levels depending on the sort of messages and the system changes that you're trying to promote. So I'm just going to skip over that. This is looking at childhood anemia and hearing health as another example of how we use health systems, protocols, auditing, KPIs, and putting all of that together in terms of improving outcomes. So some of the key messages that I've summarised for this National Aboriginal Health Summit was that improving access and the quality of comprehensive primary health care for a disadvantaged population in particular can lead to significant health improvements. And certainly I frequently will say to the primary healthcare teams that they will save more lives than anyone working in an ICU or an ED, because you're doing it across a population. So therefore you're reducing the risk across a much larger group. To be able to do that, you need to focus on health systems, and I think that's where training as a public health physician is very useful, because you develop a good understanding and appreciation of how both to understand, implement and monitor health systems improvement. And most people are not getting that in any other specialty training. So physicians, for example, or paediatricians will graduate and then recognise they need to actually start thinking about groups of patients as opposed to just individual patients, but they've got no training that enables them to really do that. So in the NT, our partnership approach has actually been of huge benefit, and I think that's one of the reasons that we have seen significant improvements in a number of the different aspects of Aboriginal health. But obviously, I think we're starting to reach the limits of what we can do as a health system in isolation. So across the country, health system improvements are fairly limited in terms of how much health gain can be achieved. There's still things that can absolutely be done, but when you're looking at a very disadvantaged population, often one of the disadvantages is around access to care. So certainly ensuring that you have improved access and you're closing the gaps around access is one thing that we can do within a health service. But we are starting to run up against the limits around, just general literacy, as well as health literacy, as well as people's ability to be employed based on their level of schooling. So until we start to see some changes in the broader social determinants, that's going to start to act as a rate limiting factor in terms of further health improvements. And then these were some of the things that I was promoting in terms of where we need to be heading next within the NT. It's around integrated patient journeys. It's around reducing racism within the health system, because that impacts on access and patient choice. It's around using the burden of disease, and as I said, injuries and poisoning is really a significant issue that I don't think we've had enough focus on. And as we're starting to see a reduction in cardiovascular mortality for Aboriginal people, we will start to increase life expectancy, and then inevitably we will get further emerging burden from cancer. Social emotional wellbeing and mental health are very significant and currently not being well addressed. And then all of the evidence in terms of early childhood and those first couple of years of life, and the difficulty in families who are very disadvantaged, the challenge of actually ensuring that the child's brain is developing effectively, which then sets them up in terms of their educational outcomes, their contact with the juvenile justice system, and future life choices. So look, I'll leave it at that. So have people got any comments or questions that you want to make?
Thanks, Christine. Just give me 1 second while I unmute everyone's microphone. You can also use the chat function, either the group chat or the chat directly to me. So just send me a message directly to Nina. We'll just give it a few seconds. There doesn't seem to be any questions. I don't know if you wanted to provide your email so that people could contact you directly in case they did have questions afterwards.
Sure. Do you want me just to say it or to email it to you, or?
Yep, you can say it out loud, or you can add it to the back to the end of the presentation if that's what you prefer.
Well, it's pretty straightforward. It's Christine.Connors, CONNORS, @nt.gov.au.
That's perfect. Thank you so much for your time, Dr. Connors. That's the end of the session. Thank you very much. Oh, hang on.
Okay, thanks everyone. See you later.
Actually, I've just got a message. Thanks. We've just got a thank you. Thank you message.